Ovarcomers, wherever you are, greetings from me and Dr. Valentine. We are going to spend the next few minutes talking to you about overcoming depression and anxiety in ovarian cancer. Now more than ever, I think this is a topic of great interest, and we are so honored to have Dr. Valentine with us today. So let's just join this conversation, and we will address your questions if you have any. So just after you watch this video, if you have any questions, feel free to send us your questions and we'll make sure we get it addressed. So with that, thank you. Thank you so much, Dr. Valentine, for joining us today.
My pleasure. I appreciate the invitation.
Thank you. And we have so many questions for you. So I will just delve right in. My first question is, I read in a recent study, which was a few months ago, that women who experienced 6 or more symptoms of PTSD at some point in their lives had a twofold greater risk of developing ovarian cancer compared to women who have not. So can you tell us about how depression and PTSD might elevate ovarian cancer risk?
Nobody is quite sure, but the prevailing theories have to do with stress hormones and their tendency to cause ovarian cancer cells to progress. A lot of that work done by Anil Sood here and his colleague Susan Mutengorf at the University of Iowa. So they've done a lot of work on this, published many papers on this subject. So the prevailing idea, and this is not strictly related to ovarian cancer, there's a lot of suspicion that stress hormones and inflammation would influence other cancers. Heart disease might make it a person more prevalent or more likely to throw a atherosclerotic plaque. So the question with depression has been known for quite a while. The Harvard study that came out, that you referenced, that came out last September, is very provocative. But in some ways not surprising. The one thing to keep in mind from that is that it was a small study, but it was significant, which was why, because it was only 16 women who in that study had high levels of PTSD symptoms. But it's a start, and it's why it was significant enough to get that published. So the idea would be stress hormones. The secondary question that has come up that those authors raised, and also that Dr. Sood's colleagues have raised, is like, is it an issue about the hormones themselves or how people process or manifest the hormones? There are some situations where individuals live stressful lives, or they work in stressful professions, and yet they cope with the stress very well. And the question is, are they then vulnerable? Is the vulnerability the same if you're a good coper? Arguably, somebody who has a high level of PTSD, having been traumatized, perhaps is not coping that well as well. Mm-hmm. So, it's an interest. I think there's a lot of data or a lot of suspicion to support the idea that it's hormones. But with regard to how one manages anxiety and depression, then it gets to that question. Well, is it that breakthrough of anxiety and depression then that triggers the neurochemical cascade?
Mm-hmm. Thank you for that. So in current medicinal practices, we stay primarily focused on clinical treatment. However, research indicates a vast majority of patients, ovarian cancer patients, feel uncomfortable raising these psychological and emotional concerns during their visits and, with the doctors. So how do you think we should address this gap? I know it's a radical question, but it is there, it's prevalent, but we don't address it as much. So how do you think we should address this gap?
Well, we could start. Sunlight's the best disinfectant. So the belief in the cancer care community or establishment is that psychosocial care is an essential component of comprehensive care. Okay? But we do this in the face of, and I'm sure we're going to talk about this a lot during this session today, we do this in the face of centuries of cultural stigma related to emotional health and mental illness. So and you don't find that when somebody is talking about coronary artery disease or about hypertension. There's no stigma associated with that for the most part. So individuals, people can feel very embarrassed. It's difficult subjects to talk about. So the main thing is to get it out there. And that needle's moved a lot. I've been practicing here for 30 years. And while there's still stigma in America regarding emotional distress and mental illness, it's better than it used to be. So folks are more willing to talk about it. I think a lot of non-mental health professionals are a lot more open to the idea. But clinicians are not necessarily mind readers either. Psychiatrists certainly aren't, despite what people might think. So it's possible that if a person doesn't bring the subject up, the clinician may not be able to pick it up on their own. So the main thing is to get it out there. I mean, if it's causing problems, then let's get it out there so we can address it.
Yeah, so talk about your feelings as much as you talk about your health and your clinical symptoms.
I think it is fair game with a primary gynecologic oncologist to say, this is really bothering me, or this is how it's bothering me. Mm-hmm. So, I think a lot of my oncology colleagues are very perceptive and they are very psychologically minded, but they don't see everything. So, a lot of centers, especially large centers like MD Anderson, do a much better job of screening with rating scales like everybody else does in medicine. But I think it is important to bring it to the attention of a clinician.
And that's great advice. Thank you. In your opinion, how does ovarian cancer impact mental health of patients in terms of not just getting diagnosed, but also for the fear of cancer coming back and just navigating through the daily lives? How do you think it impacts the overall health, mental health?
Well, there's a considerable literature on the fear of recurrence in ovarian cancer, as you know, and perhaps because this has been a tough actor to deal with among cancer types, that fear can be pretty significant. So one, it's arguably a constant source of stress and distress. And as we circle back to our first question about PTSD and about anxiety and depression and potentially always worrying, well, what's going on with your cortisol levels and your stress hormones? So that fear, in the worst case, can be paralyzing. A lot of times it's not, but it can get to the point where, it influences the way a person copes, or actually the way they don't cope, because they might not do the things they need to do to take care of themselves. So,
what would your guidance be in terms of, let's say this survivor who is going back for her scans, right? It's a reoccurrence setting that we see very often. So Absolutely. In those situations, there's a lot of anxiety, there's a lot of stress of what's to come. Right. What would be some of your guidance in terms of how to cope with that kind of stress?
At least a couple of ways to go about it. One is to acknowledge it, okay? Not tamp it down, not stuff it down. A second is to consider the possibilities. We're talking about such high stakes that the outcomes of a scan may be, really important. But just because something can happen doesn't mean that it will happen. So to the degree that it's possible to rein that in a little bit, and that's easier said than done. But there are distraction techniques. I mean, just I think it's something that a clinician also needs to know about. There are occasions like with quasi-routine follow-ups, and it's never routine for a cancer survivor, but that a little bit of medication in the days, like an anti-anxiety medication in the days or even a few weeks before a repeat visit, might help take the edge off enough to where it can be manageable. And then hopefully you get through a good scan, there's a sense of relief, and the need for the medication's not there. But I have a fair number of patients myself, and I think all my colleagues do, who, our patients are doing okay, but in that few days or maybe a week or two or even longer before that, the anxiety starts to go up. And we get through the checkup and it just goes down. But we have to help them get through it.
And what advice and guidance would you give to our survivors and overcomers in overcoming depression and mental distress during ovarian cancer?
With all of these things, it's a question in my mind of managing the distress so the distress doesn't manage you. Okay?
I love that.
Okay. We talked about this at the conference last year. I mean, cancer is inherently stressful. Okay? We don't judge that. It just is. So it's unlikely that a cancer patient or a cancer survivor or caregivers of cancer patients and survivors are going to get out of this experience without being stressed. And that stress is going to be on a continuum from things that can be pretty easily managed and don't even break through to stuff that's really disabling. But it's likely going to be there. Okay, so that self-awareness is a good starting place. All right, this is going to happen to varying degrees, but the job is to manage it. Right, and then you manage it by the ways we're talking about, by psychotherapy, by distraction techniques, by integrative medicine techniques, sometimes by use of medication. But the trick is to keep that balance in favor of the patient managing it. Mm-hmm. Depression can get so bad and anxiety can get so bad that folks don't do what they need to take care of themselves. They don't get up, they don't get out of bed, they don't dress, they don't exercise, they don't eat. And that is not in the service of cancer survivorship. So when those
that is such an important point that you just mentioned. It is such an important point to maintain the routine of the day no matter what, because that is so critical.
Easier said than done sometimes. And if it's easy, do it yourself. If it's hard, get a wingman, get some help. But the fact that one has anxiety, depression, or even PTSD is not a disaster. It's a question of managing it. Okay? Ovarian cancer patients at the same time that they are in the process of becoming ovarian cancer survivors also have to manage their cholesterol levels, right? Because there's others, you got to manage all of it. Because if you don't, something bad can happen. So, the fact that one has anxiety or depression doesn't mean it can't be managed. I mean, it's why I've got a job.
Right.
It can be done.
Correct.
And there's all different ways to do it depending on how severe it is.
Mm-hmm. So, I have to ask you this question in these circumstances, right? With COVID-19 on top of our minds as we all navigate through this uncharted path. And of course, it adds an additional layer of anxiety and stress, particularly for our ovarian survivors. And so what advice would you give to our overcomers in terms of staying aware but not anxious?
It's just that. I'm going to take a cue from my colleague, Diana Nichols, who's one of the nurses in our group who just did an in-house publication for staff at MD Anderson. And so these are not my recommendations. I sort of stole them from hers, but they're really good. The first is to look at the information sources that you're looking at. Okay? And maybe try to limit them possibly to really reliable sources. Because there's a lot of good information out there. There's information coming from MD Anderson, from COVID, coming out of the CDC, and to a degree from the Food and Drug Administration. But the further you get away from the mainstream, the more you get into stuff that could be a little bit out there, could not be accurate and may not be accurate. And for folks who are anxious and depressed, or not anxious and depressed, but are vulnerable anyway, when you're getting discordant information, that can increase your level of anxiety. It's like almost it's information overload.
Exactly.
And it's like, why aren't these people saying the same things? Maybe they don't, and that's not good for your emotional state. The second is to take care of yourself, because that, like all the things that we're talking about survivorship, those apply to crisis management, exercise, diet. Okay? It's a little hard to, well, a big problem right now, I was going to say social support, but social support right now in the age of COVID is challenged. And
we have to use technology for that, just as you and I are doing it right now.
We absolutely do, and it's being recommended.
Mm-hmm.
So, but those supports, and this gets to this idea of this other thing. I'd like to steal things from people, but with the Marine Corps slogan, improvise, adapt, overcome. Okay. Well, if you can't have your friends over to your house, then have a virtual meeting, visit with them. So, and the other thing would be, that Diana mentioned, and I really agree with, is talk about it, write about it. It's like, it's there. It's the magical thinking that if you talk about it, it's going to make things worse. It's just not supported by the evidence. I don't make a distinction between that and the fear that one might have about ovarian cancer recurrence. It's a legitimate fear. And stuffing it away serves no constructive purpose. So right now, our cancer patient population, our ovarian patients and others, do have a legitimate source of additional worry. So it's sort of limiting things, right? Limit the sources of information to reliable ones, take care of yourself, and acknowledge the obvious. Those would be my first thoughts.
And how do you think a mental health management should be integrated in overall treatment for an ovarian cancer patient? And how should our Ovarcomers take care of their mental well-being? And what are some of the hard and realistic, you mentioned that at the onset of our conversations, facts to come to terms with when you're an ovarian cancer survivor or going through treatment?
There are a lot of things to consider. Stress is part of it, okay? But I mean, the ovarian cancer patient and survivor community knows this better than anyone, how resilient our patients and survivors are. This idea that, and I'll take it back to the PTSD study, this idea that if one gets PTSD or anxiety or depression, that everything is going to fall apart is factually incorrect, okay? Statistically incorrect. Second thing to consider is that most of our patients actually do just fine. And if they wobble with some anxiety and depression, with a little help, a little structure, maybe trying some things come back to even keel, right? So the magical thing...
I'm going to intercept here just for a second. When you said trying some things, what would you recommend these patients or survivors to in terms of when it comes to, let's say, non-medicinal interventions? What would you...
It depends on the level of distress. I'm a big fan of, especially for patients who are anxious, of distraction. Because if you're thinking about something else and doing something else, you're not thinking about fear of recurrence, or you're not thinking about, when you're in active treatment, what's the outcome of that treatment going to be? Now, that's easier said than done, but the fear and the anxiety and frankly the cancer need some competition, right? So if it's all anxiety, all depression all the time, then the disease is not getting any competition. Mm-hmm. And it doesn't have to be perfect, okay? These are legitimate fears. It could be like, I'm worried about this, and I'm going to be worried about it tomorrow, but I can't be worried about it all day today because I got other stuff I got to do. But I'm going to honor the fear. It's there. I'm not going to just say this is nothing, and I'll probably worry about it tomorrow, but I can't worry about it all day, right? Because I got a life that I have to live. So for many folks, it's pretty easy to do that self-limiting themselves, but if it becomes hard, that's when you maybe ask for some help from a professional. So, the other thing that you mentioned, Sharon, is we do have this issue with stigma. Unfortunately, there's not universal health care in the United States, let alone universal mental health care. So some third-party payers make it's sometimes more difficult to access care. And that is arguably especially true in Texas, where there's not as many mental health professionals per 100,000 Texans as there are in other states. So there can be some access to care issues that come up as well. We have as a culture and a society, we have a way to go yet to where what's called the clinical mental and neurosciences get equal attention. So those can be some obstacles as well, but they can also be overcome.
Okay. I like that word. I mean, I did a virtual meeting with Dr. Coleman as well. He said overcome too, and you said overcome too. So see, that's my favorite word in solo conversation.
But you might have to get creative, okay? If you're getting blocked one way, this is what the Marines say: improvise, adapt, overcome. Right? There's more than one way to get to a goal.
Love it. My last question is, what would be your parting message for our survivors and overcomers?
Stay in the fight. If you want to use that term, and there's some question about that, but every ovarian cancer survivor became a survivor because they did things that got them to that point, right? And it wasn't all chemotherapy, and it wasn't all surgery. A lot of it was, but a lot of this is what our patients and survivors and their caregivers did too, right? This is an audience participation sport. And the evidence is clearly there. This is doable. So it may take some creativity. There is no dishonor in asking for help. Okay, that's adapting. That's improvising. If you're in a position, maybe you're just not feeling well, or you're emotionally too drained to figure out all the coping strategies yourself, then try something else. Get some help. Right? There is no dishonor in this. Ditch the stigma. Ditch the value judgments. Let's get it out there. This is doable. It simply is.
Thank you so much, Dr. Valentine, for all your fantastic guidance and all your observations that you shared with us today. I really appreciate your time. And if we do have questions, we'll make sure we bring it back to you so you can address for our overcomers.
Pleasure.
Thank you so very much.
No, thank you so much.
Thank you.